Dear Chairpersons, Dr. Purohit, Dr. Archana and Dr. Sanjay Gandhi. So dear friends, brothers and sisters, so we'll be discussing in the next few minutes on our experience using insulin pumps in adult diabetes. So Dr. Unnikrishnan was so kind to give a new topic to me. So I'll be going through some of these experiences which are more than 15 years old, as well as some of our new experiences. And this will share some ideas on when to start and when to probably stop. So I will start with a fairly new person. So this is a 62-year-old gentleman with diabetes of 2 decades. He's retired from government service, and these were the indications for him to accept an insulin pump therapy, the details of which we'll be discussing very soon. So he had severe neuropathic pain, and he had mild to moderate erectile dysfunction. And these were the baseline parameters, the A1C of 9.3, and this was his first visit, the August of 2018, and he was previously on biphasic human insulin, glimepiride, and the usual other drugs. And he was switched over to a basal bolus therapy, and he was on our routine telemedicine follow-up, which we have initiated long ago in 1997. Now we have scaled this telemedicine to another platform, and he was routinely doing the follow-up, and we did a ICGM. So this is the Libre Pro, the ambulatory glucose profile being generated from the glucose values and from the algorithm. And obviously there is a glucose variability, there is glucose instability, but there are no areas of hypoglycemia, thankful to the basal bolus regimen, and we decided to switch over to a continuous subcutaneous insulin infusion. And this was initiated in August 2018, as expected. So these were the realistic expectations, and as expected, within 1 to 2 weeks, there were improvements in the neuropathic pain. So this invariably happens with insulin pumps in most of the patients with type 1, type 2, and other types of diabetes. And within a month, there were significant improvements in sexual function. And we repeated the ICGM, and this is a very recent report. And if you look into the time in range, there is almost 98 to 99% of time which is spent in range. And for a type 2 diabetes individual, 1 or 2% time spent in hypoglycemia is probably negligible. And these are the basals currently. So in conclusion, for this particular individual, he's currently 62 years old with 20 years of diabetes and 6 months on insulin pump. And as of now, the A1C is 7.1%. So with regards to the neuropathic pain, it was way back in 2007, we presented this paper at the American Diabetes Association when one of our initial patients who came down from Germany, and he had intractable pain of neuropathy involving both the lower extremities. And we suggested insulin pump, and I saw him dancing on the 10th day, because it was for the first time in the last more than 10 years, there were some improvements in the neuropathic pain. And this prompted us to initiate an investigator-initiated trial. So this was the term we coined, EXCITED, which stands for Exploratory CSII, randomized control trial on erectile dysfunction in type 2 diabetes, which is communicated at the Journal of Diabetes Science and Technology. Of course, this is only a pilot study where we involved only 20 men, and these were the results, and there were significant improvements in the total International Index of Erectile Function scores, with improvements in the CSII arm compared against the multiple daily injections. So let me now move on to case number 2. So this is a 61-year-old gentleman, and when he consulted me first, he was working in a multinational company, and he had a diabetes of more than 28 years, and already he had a triple vessel disease for which he underwent a surgery, and these were the reasons for his visit. He was getting treated by the cardiologist, and he had continuing neuropathic pain, and he had an angina. And according to him, during the first visit, he had an angina even during mild exertion. So that limited him from lots of the routine activities, and he was again depressed. So that was limiting his routine daily activities, and these were the baseline lab and other characteristics, and we switched over to a basal bolus regimen, and then we initiated in the June of 2012, we initiated him on insulin pump. So then it was the sensor augmented pumps, and we were gradually shifting to the VAO insulin pumps, which was 530G with hypoglycemia suspend mechanisms. And currently, this is how he's performing. So now he's using 640G, and this is a very recent ICGM with the Libre Pro with almost 98% of the time. So if you look at the data, almost 98% of the time, it is a time spent in range. So now we are shifting from A1C to TIR. So gradually the global guidelines are shifting to time in range. And this is one perfect real-life experience of a subject on 640G with almost 99% time in range. And currently, he is on insulin pump for 7 years with type 2 diabetes. He is 68 years old with 35 years duration of diabetes, and A1C is 6.8%. I'm sure that you will have so many questions on how it happens, how the neuropathic pain is disappearing, how the sexual function is improving, how the anginal pain is improving. So these are some of those explanations. This is the legendary work done by Dr. Sheriello and his group. Some of you might remember these works. So this was conducted in not only type 2 diabetes, he conducted these clamp studies even in normal individuals with normal glucose tolerance. And with these clamp studies, he was trying to demonstrate what happens when the glucoses are oscillating. So this is glucose which is oscillating from 5 to 15 millimoles once in every 6 hours over a period of 24 hours. And he compared these oscillations with when the glucoses are stable and high at say 15 or 20 millimoles. And he could demonstrate with markers of oxidative stress such as flow-mediated dilatation, urinary prostaglandin. He could demonstrate that when the glucoses are oscillating, when it's moving up and down, it results in more of oxidative stress rather than when the glucoses are high and stable. So this is the fundamental aspect of glucose instability or glucose variability, whatever be the type of diabetes, resulting in oxidative stress-induced complications, which includes microvascular and macrovascular complications. So we have also demonstrated, this was way back in 2013, by calculating SD, the MAGE, and mean of daily differences, we have demonstrated that in India, the patients on multiple therapies, higher the dose of insulin, higher the standard deviation. And with sulfonylureas, there are more chances of glucose variability. Whereas, when you are appropriately programming an insulin pump, it results in the least glucose variability. I repeat, when you are appropriately programming the basals and when you're training and teaching the patients properly, adequately, it results in the least glucose variability. So we have in 2010 published the first guidelines in diabetes technology and therapeutics for India for both type 1 and type 2 diabetes. So subsequently we have the consensus guidelines for the use of continuous infusions in JAPI. So apart from the usual conventional indications, which includes uncontrolled diabetes, which includes glycemic variability, which includes the necessity for a variable basal, we have also included those indications such as any person with a desire for improving the quality of life while on insulin. So I was listening to Dr. Sanjay Gandhi's oral presentation yesterday when he briefed on all these indications. So we have broad indications since insulin pumps are advanced gadgets for insulin delivery. So these are all the patients whom they are indicated. And these are some of the extended or compelling indications which we have probably included in the guidelines from our past experiences. Over to case number 3. So obviously we can make a diagnosis from this X-ray. So this is a subject with pancreatic diabetes. So this is pancreatic calculi, a 37-year-old school teacher with frequent episodes of severe hypoglycemia. So many of you probably will have 3 or 4 patients in our practice with fibrocalculous pancreatic diabetes. So these were the baseline characteristics. He was initiated on pump almost 10 years ago. And these are patients who will require tiny doses of basal and bolus. Very, very insulin sensitive. She's quite stable. Currently, she's 48 years old with 20 years of diabetes. Very, very stable, but probably dependent on insulin pump for her tiny bolusing, very frequent tiny bolusing, and for these tiny basals. And we have probably many, many other indications. This is one of my own papers in the Journal of Pakistan Medical Association. We are good friends. We are good friends with the Journal of Pakistan Medical Association. And this is insulin pump in diabetes and pregnancy. Let me share a failure with you. Because in real life, in clinical practice, we come across failures. These failures can come across even with these expensive gadgets. So this is an example or a story, a real story of a failure with a patient on insulin pump. That has also happened. That has happened to probably most of us. And this is a social worker with diabetes of just 8 years old. And these were the indications for him to opt an insulin pump therapy. And this was way back in 2005, so long ago. So insulin pumps were introduced in India in 2004, 2005. So the earlier 5 to 6 years, it was only a 7-on-5, and then it was 7-2-2. And he was initiated on a basal bolus regimen. And in the June of 2005, this guy was started on insulin pump therapy. Within a couple of weeks, he reported dramatic improvements as usual, as expected, in neuropathic pain, in sexual function. And let me tell you, he was properly using the insulin pump for over 6 to 7 years. Regular follow-up, regular monitoring, very, very motivated and educated. But somehow, he was easily influenced by the proponents of unproven therapies, unscientific therapies, very much prevalent in India. And he opted for naturopathy, he opted for Ayurveda, he stopped insulin pump, and he actually stopped insulin pump for more than 3 to 4 years. He was even intermittently only with insulin. So even insulin he discontinued. The creatinine went up, the EGFR dropped, he went for an angioplasty, there were recurrent foot ulcers, bilateral performed neuropathy, and he again came back. And this time, he opted for a 640G, which is the artificial pancreas for us in Asia. But again, he went for a keto diet. And things were actually not improving. He was deteriorating, and this is the current state. I just wanted to share this story with you. Usually, with an expensive gadget, the failures happens within the first 3 to 4 months. Because many patients believe that I am already on a very expensive gadget, and it's going to cure my diabetes. It's a panacea. And hence, you need to have a regular virtual follow-up, and periodic retraining is absolutely essential. So we have learned a lot of lessons, and this is one example of a 640 download. And you have the glucose kinetics over there in the upper panel, and this is the insulin kinetics. So in 640G download, whenever the glucoses are dropping, you can visualize that there is an automatic suspension of insulin release. Thereby, there is no hypoglycemia. So in the previous pump, it is at the time of hypoglycemia the insulin will get suspended. But this is almost 30 minutes before hypoglycemia. So this is predicted. And when the values are back to, say, on an average 95 to 100 milligrams, the insulin delivery automatically resumes. So this guy is on pump for more than 14 years, and this is the current A1C. So if somebody asks you, where is the evidence for insulin pumps in type 2 diabetes? Of course, we have so many publications from all over the world, but this is the largest controlled trial that is optimized. Use of insulin pumps in type 2 diabetes compared against multiple daily injections, demonstrating consistently superior reduction in A1C with twice as many patients achieving an A1C below 8% in the pump cohort compared to those on multiple daily injections. And when this optimized was published in Lancet, we too were excited because our own study in type 2 diabetes published maybe 6 years before this clinical trial appeared as a reference in this article. So sharing one story of a type 1 diabetes. I know the next lecture is on type 1 diabetes. So this is a 34-year-old teacher. And these were the indications. The CGM again demonstrated the classical pattern of a type 1. So it's a roller coaster ride in the CGM. And we decided that the subject should opt for an insulin pump. His C-peptide is 0. So any subject with type 1 diabetes is probably a candidate for insulin pump. And these are the current numbers. Type 1 duration for 22 years and A1C 7.8. 7.4, and on insulin pump for 14 years. So we have attempted to publish another data of patients, and we try to assess those patients who were on insulin pump for a longer period of time, 7 years, 10 years and more. And uniformly, majority of them appreciated that there is a continuing improvement in the quality of life, which is consistently observed with insulin pumps. And they expressed that there is a very high level of satisfaction. And majority agreed that the expectations were real and the pump met their expectations. So we are moving forward. So from 640, it is 670G with automation of the basal delivery. So there is one more hybrid closed-loop system, that is a diab-loop hybrid closed-loop system, which is currently approved in Europe. So there are many, many players coming up, but Medtronic Minimed, still they are the leaders, and this is expected in 2020. That is Minimed 780G, which is an advanced closed loop with automated correction boluses. And in another 3 years, we are expecting 890G, and 890G is aiming at more than 85% time in range. And this is in type 1 diabetes. What I have shown is in type 2 diabetes. And another dream come true. Another dream come true. The insulin, the fuel, the right fuel for insulin pumps, and the ideal bolus insulin for type 1 and type 2 diabetes. So this has got approved in India as well. There is a faster acting insulin aspart with 74% more action, glucose lowering action in the first 30 minutes with a faster onset and a faster offset of action. So let me conclude with this statement. Whenever you have patients, especially adults, eligible for opting a continuous subcutaneous insulin infusion, please remember, majority of our patients eligible for an insulin pump or an advanced gadget for insulin infusion, they are not aware. Even many of our colleagues are not aware that these gadgets and advanced devices are available in India. So they should be given the options. You should discuss with them because the benefits are phenomenal. It tremendously improves their quality of life. So never deny the benefits to those patients who can really access it. So thank you so much for this opportunity and for your patient hearing.